This e-lecture will be over tuberculosis, or TB, which can be found in Chapter 27 of your Lewis textbook. TB usually involves the lungs, but any organ, including the brain, kidneys, and bones, can be infected. Currently, the CDC reports that more than 2 billion people are infected with TB. The incidence of TB worldwide declined into the mid-1980s when HIV disease emerged. The factors that contributed to the resurgence of TB were high rates of TB among patients with HIV and the emergence of multi-drug resistant strains of M. tuberculosis. Although the prevalence of TB has increased in Europe, it has steadily declined in the U.S. since reaching a resurgence in 1992. TB occurs disproportionately in the poor, underserved, and minorities. In the U.S., people most at risk include the homeless, residents of inner-city neighborhoods, foreign-born persons, those living, working in institutions such as prisons, hospitals, IV-injecting drug users, low socioeconomic people, and those with poor access to health care. Immunosuppressant from any etiology such as HIV, long-term corticosteroid use increases the risk of active TB infection. Once a strain of M. tuberculosis develops resistance to two of the most potent first-line anti-tuberculosis drugs, such as rifampin, it is defined as multi-drug resistant TB. Extensively, drug-resistant TB occurs when the organism is also resistant to any of the fluoroquinolines plus any injectable antibiotic agent. Resistance results from several problems, including incorrect prescribing, lack of public health case management, and patient non-adherence to the prescribed regimen. M. tuberculosis is a gram-positive, acid-fast bacillus that is usually spread from person to person via airborne particles expectored when breathing, talking, singing, sneezing, and coughing. A process of evaporation leaves small droplet nuclei. These droplets contain M. tuberculosis. Because they are so small, the particles remain suspended in the air for minutes to hours, and bacteria are then inhaled by another person. TB is not highly infectious, as transmission usually requires close, frequent, or prolonged exposure. Factors that influence the likelihood of transmission include the number of organisms expelled into the air, concentration of organisms, length of time of exposure, and the immune system of the person exposed. When the focus of infection is established through inhalation, it is called the Goen lesion or focus, which represents a calcified TB granuloma, the hallmark of TB. The formation of a granuloma is a defense mechanism aimed at walling off the infection and preventing further spread. Replication of the bacillus is inhibited and the infection is stopped. Most immunocompetent adults infected with TB are able to completely kill the mycobacterium. Some people contain the mycobacterium in a non-replicating dormant state. Of these individuals, 5 to 10% will go on to develop active TB infection when the bacteria begins to multiply months or years later. M. tuberculosis is aerophilic or oxygen-loving and thus has an affinity or a liking for the lungs. However, the infection can spread via the lymphatic system and find favorable environments for growth in other organs, including the cerebral cortex, spine, the epiphyses of the bone, and adrenal glands. Several systems can be used to classify TB. The American Thoracic Society classes TB based on the development of the disease. TB can also be classified according to the presentation. Is it primary, latent, or reactivated, and whether it is pulmonary or extrapulmonary? Primary TB occurs when the bacteria are inhaled and initiate an inflammatory response, a reaction. The majority of people mount effective immune responses to encapsulate these organisms for the rest of their lives. preventing primary infection from progressing to the active disease. Latent TB is a TB infection in a person who does not have active TB. People with latent TB have a positive skin test but are asymptomatic. These individuals cannot transmit the TB to others but can develop active TB at some point. Immunosuppression, diabetes, nutrition, aging, all can precipitate the activation of latent TB. Consequently, treatment of TB is important. If the initial immune response is not adequate, the body cannot contain the organism, and as a result, the bacteria replicate and active TB disease results. When active disease develops within the first 2 years of the infection, it is termed primary TB. Individuals co-infected with HIV are at the greatest risk for developing active TB. Post-primary or reactivation TB is defined as TB disease occurring 2 or more years after the initial infection. If the site of TB is pulmonary or laryngeal, the individual is considered infectious and can transmit the disease to others. People with latent TB have a positive skin test but are asymptomatic. Symptoms of pulmonary TB usually do not develop until 2 to 3 weeks after infection or reactivation. The characteristic pulmonary manifestation is a dry cough that frequently becomes progressively productive with mucoid or mucopurulent sputum. Active TB disease may initially manifest with constitutional or general symptoms such as fatigue, malaise, anorexia, low-grade fevers, and night sweats. Dyspnea is a late symptom that may signify considerable pulmonary disease or pleural effusion. Hemoptysis, or bloody sputum, which occurs in less than 10% of patients with TB, is also a late symptom. Sometimes TB has a more acute sudden presentation. The patient may have a high fever, chills, generalized flu-like symptoms, pleuritic pain, and a productive cough. Auscultation of the lungs may be normal or reveal crackles and/or bronchial breath sounds. The clinical manifestations of extrapulmonary TB are dependent on the organs infected. For example, renal TB may cause difficulty urinating and bloody urine or hematuria. Immunosuppressed people such as HIV and older adults are less likely to have fever and other signs of infection. In patients with HIV, classic manifestations of TB such as fever, cough, and weight loss may be wrongly attributed to pneumocystis jirovecii pneumonia or other HIV-associated opportunistic diseases. Clinical manifestations of respiratory problems in patients with HIV must be carefully investigated to determine the cause. A change in cognitive function may be the only initial presenting sign of TB in an older person. Appropriately treated, pulmonary TB typically heals without complications except for scarring and residual cavitation within the lung. Significant pulmonary damage, although rare, can occur in patients who are poorly treated or who do not respond to TB treatment. Miliary TB is the widespread dissemination of the mycobacterium. The bacteria are spread via the bloodstream to several distant organs. The infection is characterized by a large amount of TB bacilli and may be fatal if left untreated. It can occur as a result of primary disease or reactivation of latent infection. Clinical manifestations of miliary TB slowly progress over a period of days, weeks, or months. Symptoms vary depending on the organ that are affected, including fever, cough, lymphadenopathy, hepatomegaly, and splenomegaly if the liver and spleen are involved. Pleural TB, a specific type of extrapulmonary TB, can result from either primary disease or reactivation of a latent infection. Chest pain, fever, cough, and presence of unilateral pleural effusion are common. Pleural effusion is characterized by bacteria in the pleural space, which triggers an inflammatory reaction and pleural exudate of protein-rich fluid. Empyema is less common than effusion but may occur from large numbers of tubercular organisms in the pleural space. Diagnosis is confirmed by acid-fast bacillus cultures and a pleural biopsy. Because TB can infect other organs, various acute and long-term complications can occur. TB in the spine, or POTS with double T disease, can lead to the destruction of the intervertebral disc and adjacent vertebrae. Central nervous system TB can cause severe bacterial meningitis. Abdominal tuberculosis can lead to peritonitis, especially in HIV-positive patients. The kidneys, adrenals, glands, and lymph nodes and urogenital tract may also be affected. The tuberculin skin test, or the MAN2 test, using purified protein derivative, or PPD, is the standard method to screen people for M. tuberculosis. The test is administered by injecting 0.1 ml of PPD intradermally on the ventral surface of the forearm. The test is read by inspection and palpation 48 to 72 hours later for the presence or absence of induration. The indurated area, if present, is measured and recorded in millimeters. Induration, a palpable raised, hardened area of swelling, not redness, at the injection site, means the person has been exposed to TB and has developed antibodies. Antibody formation occurs 2 to 12 weeks after initial exposure to the disease or bacteria. The induration is measured, and based on the size of the induration and the risk factors, an interpretation is made according to the standards for determining a positive skin reaction. An induration of 15 millimeters or more is considered positive in all low-risk individuals. Results for patients at high risk would be considered positive if induration 10 millimeters or higher. Because the immunocompromised patient may have a decreased response to TST, even smaller induration reactions, such as greater or equal to 5 millimeters, are considered positive. The figure shows a positive tuberculin skin test. This adolescent boy became infected as a result of living with and helping to care for a grandfather whose chronic smoker's cough was ultimately discovered to be a manifestation of chronic cavitary tuberculosis. He had a greater than 15 millimeter induration. Some people who are previously infected with TB may have a waning immune response to the TST. This may result in a false negative response or result. However, repeating the TST may stimulate or boost the body's ability to react to tuberculin in future tests. A positive reaction to a subsequent test could then be misinterpreted as a new infection, rather than the result of the boosted reaction to an old infection. To prevent misinterpretation in future testing, a two-step testing process is recommended for initial testing for healthcare workers and for individuals who have a decreased response to allergens. A previously negative two-step TST ensures that any future positive results can be accurately interpreted as being caused by a new infection. Interferon Y gamma release assays, or IGRAs, provide another screening tool for TB. IGRAs are a blood test that detects INF gamma release from T cells in response to Mycobacterium tuberculosis. Examples of IGRAs include quantiferon TB test and the T-spot. Test results are available in a few hours. IGRAs offer several advantages over the TST in that they require only one patient visit, are not subject to reader bias, have no booster phenomenon, and are not affected by prior BCG vaccinations. The cost of an IGRA is substantially higher than the TST. Current guidelines suggest that both tests are viable options and that selection should be based on context and reasons for testing. Neither IGRAs or TST can distinguish between latent and active TB infection. Latent can only be diagnosed by excluding active TB. Although the findings on chest X-ray examination are important, it is not possible to make a diagnosis of TB solely on chest X-ray findings. The chest X-ray may appear normal in a patient with TB. Findings suggestive of TB include upper lobe infiltrates, cavitary infiltrates, lymph node involvement, and pleural and pericardial effusions. Other diseases, such as sarcoidosis, can mimic the appearance of TB. 3 consecutive sputum specimens collected on different days are obtained and sent for smear and culture. The initial testing involves a microscopic examination of stained sputum smears for acid-fast bacillus. However, the definitive diagnosis of TB requires the demonstration of tubercle bacilli bacteriologically by sputum culture, which can take up to 8 weeks. Treatment is warranted pending the culture results for patients in whom clinical suspicion of TB is high. Samples for other suspected TB sites can be collected from gastric washings, cerebrospinal fluid, or fluid from an abscess or effusion. Most patients with TB are treated on an outpatient basis. Many people can continue to work and maintain their lifestyle with few changes. Patients with sputum smear positive TB are generally considered infectious for the first 2 weeks after starting treatment. Advise these patients to restrict visitors, avoid travel on public transportation and trips to public places, and on the importance of good hand washing and oral hygiene. Hospitalization may be needed for the severely ill or debilitated. The mainstay of TB treatment is drug therapy. Promoting and monitoring compliance is critical for treatment to be successful. Because of the growing prevalence of multi-drug resistant TB, it is important to manage the patient with active TB aggressively. Drug therapy is divided into 2 phases, initial and continuation. In most circumstances, the treatment regime for patients with previously untreated TB consists of a 2-month initial phase with 4 drugs. If drug susceptibility test results indicate that the bacteria are susceptible to all drugs, ethambutol may be discontinued. If PZA cannot be included in the initial phase due to liver disease or pregnancy, the remaining 3 drugs are used for the initial phase. Teaching patients about the side effects of these drugs and when to seek prompt medical attention is critical. The major side effect of isoniazid, rifampin, is non-viral hepatitis. Baseline liver function tests are done at the start of treatment. Monthly monitoring of liver function tests is done if baseline tests are abnormal. Drug alert on isoniazid. Alcohol may increase hepatotoxicity. Instruct patients to avoid drinking alcohol during treatment. If the patient develops a toxic reaction to the primary drugs, other drugs can be used, including rifabutin. Treatment for drug-resistant TB is guided by sensitivity testing. Noncompliance is a major factor in the emergence of multi-drug resistance and treatment failures. Many individuals do not adhere to the treatment program despite understanding the disease process and the value of treatment. Directed observed therapy, or directly observed therapy, DOT, involves providing the anti-tuberculosis drugs directly to the patients and watching as they swallow them. To ensure adherence, it is the preferred strategy for those at risk for non-compliance. DOT is an expensive but essential public health issue. The risk for reactivation of TB and multi-drug resistance. TB is increased in patients who do not complete the full course of therapy. In many areas, the public health nurse administers DOT at a clinical site. In people with latent TB, drug therapy helps prevent a TB infection from developing into active TB disease. Because there are few bacteria in a person with latent TB, treatment is much easier. Usually only one drug is needed. The standard treatment regime for latent TB is 9 months of daily isoniazid. It is an effective and inexpensive drug that the patient can take orally. The 9-month treatment is effective, but compliance issues may make the 6-month regimen preferable. For HIV patients and those with fiber optic lesions on chest X-ray, isoniazid is given for 9 months. An alternative 3-month regimen of isoniazid and Prifton may be used for otherwise healthy patients who are not presumed to be infected with drug-resistant bacilli. A 4-month therapy with rifampin may be indicated if the patient is resistant to isoniazid. Due to the severe liver injury and deaths, the CDC does not recommend the combination of rifampin and pyrazinamide for the treatment of latent TB. BCG vaccine is a live attenuated strain of Mycobacterium bovis. The vaccine is given to infants in parts of the world where there is a high prevalence of TB. In the U.S., it is typically not recommended because of low risk of infection. The vaccine's variable effectiveness against adult pulmonary TB and potential interference with TB skin test reactivity. The BCG vaccine should be considered only for very select individuals who meet specific criteria, such as healthcare workers continually exposed to patients with multi-drug resistant TB, and infection control precautions are not successful. The BCG vaccination can result in a false positive tuberculosis skin test. IGRA results are not affected. Ask the patient about a previous history of TB, chronic illness, or any immunosuppressive medications. Obtain social and occupational history to determine risk factors for transmission of TB. Assess the patient for productive cough, night sweats, afternoon temperature elevation, weight loss, pleuritic chest pain, and abnormal lung sounds. If the patient has a productive cough, early morning is the ideal time to collect sputum specimens for an acid-fast bacillus or AFB smear. Nursing diagnoses for the patient with TB may include, but are not limited to, the following: ineffective breathing pattern, ineffective airway clearance, risk for infection, noncompliance, fatigue, noncompliance and ineffective healthcare management related to the lack of knowledge of disease process, lack of motivation, and long-term nature of treatment, and maybe the lack of resources. The overall goals for the patient with TB is that they will comply with a therapeutic regime or regimen, the medications, the long-term use of the medications, that they will have no recurrence of the disease, they will have normal pulmonary function, and that they will take the appropriate measures to prevent the spread of the disease. The ultimate goal is to eradicate TB worldwide. Screening programs in known risk groups are of value in detecting individuals with TB. Treatment of latent TB reduces the number of TB carriers in the community. The person with a positive TB test should have a chest X-ray to assess for the presence of active TB disease. Individuals with a diagnosis of TB must be reported to the public health authorities for identification and assessment of contacts and risks to the community. Programs to address the social determinants of TB are necessary to decrease transmission of TB. Reducing poverty, overcrowded living conditions, malnutrition, smoking, and drug and alcohol abuse can help minimize TB infection rates. Improving access to health care and education is also important. Patients admitted to the ER or directly to the nursing unit with respiratory symptoms should be assessed for the possibility of TB. Those strongly suspected of having TB should be placed on airborne isolation, receive a medical workup including chest x-ray, sputum smear, and culture, and receive appropriate therapy. Airborne infection isolation refers to isolation of patients infected with organisms spread by the airborne route. It requires a single occupancy room with negative pressure and airflow of 6 to 12 exchanges per hour. High-efficiency particulate air masks, or HEPA masks, are worn whenever entering the patient's room, and these masks are highly effective at protective from small particles. Airborne infection isolation is indicated for the patient with pulmonary or laryngeal TB until the patient is non-infectious. This is a picture of a high-efficiency particulate air HEPA mask. Because many different types of HEPA masks are currently available, healthcare professionals should be fit tested each time a different brand or model of mask is used to ensure proper mask size. Otherwise, the CDC recommends that yearly mask fit testing is acceptable. To be effective, the mask must be molded to fit tightly around the nose and mouth. Teach patients to cover the nose and mouth with paper tissues every time they cough, sneeze, or produce sputum. The tissues should be thrown into a paper bag and disposed of with the trash, burned, or flushed down the toilet. Emphasize careful hand washing after handling sputum and soiled tissues. If patients need to be out of the negative pressure room, they must wear a standard isolation mask to prevent exposure to others. Minimize prolonged visitation to other parts of the hospital. Identify and screen close contacts to the person with TB. Anyone testing positive for TB infection will undergo further evaluation and needs to be treated for either latent TB or active TB disease. Patients who have responded clinically are discharged home even with positive cultures if their household contacts have already been exposed and the patient is not posing a risk to others. A sputum specimen for acid-fast bacillus smear and culture should be obtained at a minimum of monthly intervals until 2 consecutive sputums are negative. More frequent acid-fast bacillus smears may be used to assess the early disease treatment and to provide an indication of infectiousness. Teach patients how to minimize exposure to close contacts and household members. Houses or homes should be well ventilated, especially the areas where the infected person spends a lot of time. While still infectious, the patient should sleep alone, spend as much time as possible outdoors, and minimize time in congregate settings or public transportation. Teach the patient and caregiver about compliance with the prescribed regimen. This is very important as most treatment failures occur because the patient neglects to take the drug, discontinues it prematurely, or takes it irregularly. Strategies to improve adherence to drug therapy include teaching and counseling, reminder systems, incentives or rewards, contacts, and dot therapy. Notification of the public health department is required. The public health nurse will be responsible for follow-up on household contacts and assessment of the patient for compliance. If compliance is an issue, the public health agency may be responsible for DOT. Most individuals can be considered adequately treated when the therapy regimen has been completed and there is evidence of negative cultures, clinical improvement, and improvement on chest x-ray. Because about 5% of individuals experience relapses, teach the patient to recognize the symptoms that indicate recurrence of TB. If these symptoms occur, the patient should seek immediate medical attention. Instruct the patient about certain factors that could reactivate TB, such as immunosuppressive therapy, malignancy, and prolonging debilitating illness. If the patient experiences any of these events, the healthcare provider must be told so that the TB can be closely monitored for reactivation. In some situations, it is necessary to put the patient on anti-TB therapy. Because smoking is associated with poor outcomes in TB, patients should be encouraged to quit, provide patients with teaching and resources to help them stop smoking. The expected outcomes are that the patient with TB will have the resolution of their disease, normal pulmonary function, absence of any complications, and no further transmission of TB.